Hello and welcome. This is presentation one, and this is an overview of deaf children, young people, their families, with regards to child and adolescent mental health services. Okay, so today I'd like to just start with how we initially became a service active in the UK. So we're a national deaf child and adolescent mental health service in England. And we're based, it was originally because we were set up originally because it was identified that there was a gap in service provision for deaf children to access mental health services, and for also hearing children who have deaf parents who likewise would have difficulty accessing hearing mainstream mental health services. So around 2006, there was funding agreed and a pilot was set up in York, which is, as you can see on the map, around central there in the middle, towards the east. By 2009, it had expanded and there were 10 outpatient services with one national inpatient service in London. So it was 2009 when I set up the Manchester team. The York team was already established. Newcastle team was set up and followed Dudley, Nottingham, Oxford, South London, Cambridge, Maidstone and Taunton. This generally covers like the whole of England. So the north of England is set up with the three teams of York, Manchester and Newcastle, and that's where Vicky and I work. When it comes to the differences, the slight differences between the deaf services for children with mental health needs and hearing, in that the numbers are a lot less and it's a rather specialised area. And so our caseload is a lot less. So for example, the three teams, as I mentioned, the York, Manchester, Newcastle, the average caseload would be around 150. Again, yes, that's a very small number. We'll get referrals on average about 1 to 2 a week per team. For hearing CAMHS, their caseload is much bigger than ours. And so therefore, they will probably get 1 to 4 referrals per day. However, saying that there are a lot more services across the United Kingdom. There can even be hearing CAMHS services can actually have maybe 3 or 4 per town, where our services cover a much bigger geographical area. So a hearing CAMHS service on average will have about 20 staff, and each staff member will have a caseload of 30 plus. However, your deaf CAMHS staff, on a deaf team, our staff members will be around 7 per team, and individual caseloads will range between 8 and 10, which is much more manageable. Hearing services thresholds are much higher than deaf CAMHS. This again is due to higher number of referrals. So what happens is they're unable to do like the preventative work that causes more serious and develops into more serious mental health issues, where we're able to deal with the more preventative work early on. That's the aim anyway. Each team is set up. We have, for each of the 3 teams mentioned, we have a psychologist, a psychiatrist, also known as a medic. We have admin. We usually have a registered mental health nurse or a social worker and a manager. And in addition, that is what you would normally get with a hearing CAMHS service, but to make us different, we actually employ and need deaf specialist outreach workers and freelance BSL English interpreters. Okay. Quite early days, we realised as hearing practitioners that a lot of the research and the practice for the assessments, the research and practice, and also which influenced our assessments and intervention, is based on hearing people. So it's all based on the hearing population. And so what we needed to do was adapt these so that they were accessible and meaningful for our deaf children. And to do this, as hearing staff members, we really did rely on, and still do, rely on our deaf outreach workers and our BSL interpreters. Over time, as the service sort of like developed and grew, we actually, at the start, we only brought in freelance interpreters, excuse me, ad hoc, as and when we thought we needed them. And over time, we realised that we were handpicking specific interpreters, and we were booking the same ones every time. And we realised that actually we needed to adapt to the way we were working, and we needed the interpreters on site all the time. They were changing and learning and developing just as we were. And because of that, we realised that every appointment, pretty much, when we're working with deaf children and their families, is that we realise that we need the specialist mental health clinician who's hearing. We need the deaf outreach workers, lived experience, and we need the BSL interpreter. And this wasn't something that we could bring on an ad hoc basis anymore. And so we brought them in as in-house interpreters, as paid employees like the rest of us. Next slide, please. Okay, so criteria for deaf CAMHS. So we range from, we're open for people aged 0 to 18 with emotional and behavioural concerns. We tend to say emotional and behavioural concerns rather than mental health problems or mental health issues. That tends to be more of an adult terminology. And we also work a lot with families. To be referred, you need to have a severity of mental health. As I said before about working with thresholds, we try and work with prevention more than actually trying to manage the mental health. So for example, when I talk about severity, so for example, we might get a referral for bereavement, where actually we won't actually touch bereavement because this is a normal process that people and children should go through. However, a year or two down the line, if the child still hasn't gone through the usual processes and they're becoming a bit low in mood, it could end up being a bit more damaging. And so that's where the normal processes haven't worked, and that's when we would then step in. Another example would be a child refusing to go to school, for example. But again, it depends on the reason. They can't not go to school and ask our involvement for help just because they don't like school. However, if they're having anxiety or palpitations or difficulties breathing with the thoughts of going to school, then that's a bit different. So that's when we would accept the referral. So that's the severity of mental health. Next, we look at, they also have to have a level of hearing loss. So we look at, we usually tend to ask for an audiogram along with the referral form, which is our request, the request for us to get involved, and which I'll talk about on the next slide. And the difference with the severity of the hearing loss is predominantly if we're set up to work with those children and families who can't access mainstream hearing services. And so we don't want to get blocked with those people. Those people need to go to the hearing services, and we see the ones who can't. That's what we're commissioned and paid funding to do. We will actually accept children with a moderate hearing loss, which again, I'll explain on the next slide, if they've got some language issues, which again means they couldn't vocalise themselves clearly and be understood necessarily by hearing services. We'll also work with hearing children who have deaf parents, and again that's because the deaf parents would struggle to access hearing services because they haven't adapted their service provision to allow them to have access. So as I said, this is the audiogram that we tend to go from. So an audiogram is something that will get, all kids will have hearing tests from when they're diagnosed from having a hearing loss, and this will let people know, let us know the level of hearing on the left side and the right side. So they measure it in decibels. So the decibels go from 0 to 120. And as you can see, there's a normal hearing range, which is from 0 to 25. And then the other areas are split up into different levels of hearing loss. The black line is the left ear, and the right line is the red line, sorry, is the right ear. Okay. So here is, depending on where that line falls, this then enables us to find out whether they would meet our criteria. So we wouldn't work with anybody with a normal hearing ability unless the parents were deaf. We wouldn't do mild hearing loss because, again, they could usually access mainstream CAMHS. You then look at the moderate, which ranges between 40 and 70 decibels. That will depend on their language and access to language and information, whether they access our service. Then from 70 decibels onward, you've got severe and profound. And that's the usual category of what the children we would work with and why we're funded. Okay, next slide, please. So just to differentiate, I've mentioned about hearing child services and deaf child services, and the differences is usually around language and communication and access to information. There's also, I thought I'd explain about the difference between child and adult mental health services. So for adult services, I've worked in before I came here to work with children. They would have, it would be a self-referral. For example, the individual could just ring up and ask for support, where our services for deaf children is very much a referral from professionals. And most of all, the professional that tends to contact us and make referrals are teachers of the deaf. And this is usually because every child in the UK who has deafness, have hearing loss, they will tend to have and be allocated a teacher of the deaf. And if the problems and the difficulties are more than school can manage or more than parents can manage, then that usually meets our threshold, and that's when the referral from the teacher of the deaf comes in. We will, however, because we're systemic, which means we'll work with all professionals and family members, we'll get referrals from GPs, paediatricians, social care or welfare officers, and we work with all those people as well as the parents and the child. Reasons for referral for adults, they vary, but actually they don't need a reason other than they need help and they think they've got mental health issues, and they'll get an assessment. Majority of our referrals for our children tend to be questioning behaviour. They're not looking at the cause of behaviour, but it's the behaviour that they can't manage, and that's why they tend to refer for behaviour. We'll look later at what I'll go through other types of reasons for referrals. We'll work through the slides in the presentation. Case history. This is where you gather historic information that helps to inform your assessment. For adults, the case history is much longer than children. In addition, to make like really good assessments, and when you're looking at diagnosis, you also need the early years history. So for example, if somebody came into an adult service and they were querying whether they had autism or not, the first thing, one of the key points for diagnosing autism is the early years development and how delayed it is. It's not always the reason, but it's part of the assessment. And yet adults won't tend to have this sort of information, like what age did they crawl, what age did they walk, when did they say the first words. Because we work with parents and children, we have that information at hand. So our assessments to case history is much shorter and much easier, which helps us do a much thorough assessment. The other thing about case history, about working with adults and the case history is, for example, if an adult goes for autism, again, I'll use that as another example, by the time they're reaching by the time they've reached adulthood, they've actually learned some self-strategies to manage things like eye contact. So for example, that's just one of the things that the criteria for autism, but one of what they'll do is, instead of looking at you in the eye, they've learned to look here. So it looks like they're looking you in the face, but they're not. They're actually learned strategies. And these strategies start to mask actually what's going on. So it's much harder to unpick. For adult services, frontline sort of therapy can actually be medication rather than actual one-to-one therapy. Or they'll do the two together, where in children's services, medication's the last resort. And that's mainly because of the side effects and the impact on the child development. Then we've got mental health. I've said before, with adults, it's more about management, because the preventative work that could have been done as a child didn't happen. We're able to do that. That's our aim. Our services for children is very much in and out. You come in, we see what's going on, we do the work and the help and the therapy, and the idea is to get you out so that you're no longer relying on mental health services, which, unlike that's what can happen within adult services, is that you don't do a short stint, you actually spend quite a good part of your life in it. For children, we don't tend to do formal diagnosis around mental health. And again, I've got a slide coming up to explain the difference. Where adults, it's much more formally diagnosed, so then it can be treated, because you need a diagnosis to have medication, but you don't need a diagnosis to have therapy. You actually start to treat the symptoms with therapy. And terminology, as I said before, with adults, it's called mental ill health. Terminology for children, we try not to label as mental ill health. It's more emotional and behavioural difficulties at that time. They haven't emerged into mental ill health just yet. Next slide, please. So as I said before, this is trying to give you a bit of a difference between the child versus adult diagnosis. So in children's services, we'll get a referral for query autism, and we may or may not diagnose a child with autism, and that's a formal diagnosis. In adults, it's more adult autism, or it can even be more Asperger's, because again, like I said before, they've started to learn some strategies that masks the actual true autism difficulties that they've got. For children, we would say that they've got low mood, because that's where it's at when they come to be referred to us. They're low in mood. But over time, if it's not treated and they move and transition into adulthood, a mental health adult service would actually diagnose it more of a mood disorder and give it a formal diagnosis as depression or bipolar. Bipolar meaning that they can have, they can go from very low to being very manic. Anxiety, we would do that as a circumstantial anxiety. It's quite mild. So it means like they don't feel good about going into school. It can make them anxious about speaking to people in the playground or getting on the bus. But actually they can function okay to a degree. As an adult, if that continues, their functioning abilities start to decrease, and they start to stay at home, they don't go out, and they avoid things. And they don't have parents to push them and teachers to encourage them. They can be quite isolated. And so the anxiety can turn into an anxiety disorder because it's so disabling, where they just can't leave the house, for example. ADHD and ADD. So ADHD is attention deficit hyperactive disorder. So that means they've got problems with their attention and concentration, and they're quite hyperactive. ADD is just attention deficit, so it's just the concentration side, and yet they're not all fidgety and they don't have trouble with the hyperactivity. As a rule, children tend to get diagnosed this, people tend to get diagnosed this as a child. As an adult, it tends to be missed. They're seen as fidgeters, or people who can't concentrate, people who can't organise themselves, they forget things, and so it gets completely missed as attention deficit hyperactivity disorder. As a child, you'd be diagnosed as having eating problems or eating difficulties. Again, prolonged, if untreated, becomes an adult. It can be classed as anorexia or bulimia. We say our children have sleep issues, and so we help them with like good sleep routines, sleep patterns. We teach parents as well, so they can also do those routines every night. Again, if left, it could be diagnosed as, in adulthood, as insomnia. Okay. Next slide, please. Okay. I've already done sleep issues. So deaf identity. You wouldn't normally get a referral to hearing or deaf adult mental health services with deaf identity. It starts off as an identity issue as a child, but again, this is where they're questioning where they fit in society, why they're different, and the impact on that, if it's not dealt with and they don't feel comfortable within their own body about themselves mentally, that can turn into isolation and depression in adulthood. And so that's would be what they would be diagnosed with. So you can see the transition if not dealt with in childhood. And that's why I keep saying it's all about preventative work where possible. We will diagnose our children with social or emotional developmental delay. And that can be because they're premature or be due to their deafness. They haven't had access to information that helps them to develop and grow as a hearing child would. Where an adult would not be diagnosed with that. They would tend to, by adulthood, be looking like meeting the criteria of someone who's got a learning difficulty or someone who can't manage their emotional regulation. They can't manage their emotions and they become aggressive. They can be deemed as being an aggressive person. Trauma, we get all varieties of trauma, from neglect. The reasons for trauma can vary. It can be a death in the family, traumatic death, a car accident, lots of different reasons things can cause a class as trauma. In adults, they call it trauma-related disorders. Again, if left untreated, moves into adulthood, it's classed as post-traumatic stress disorder. And again, it's given a formal diagnosis and a criteria is met to achieve that. Okay. Next on the list is language deprivation. This is quite an up-and-coming thing in the UK. It's much more advanced in America. And this is where our hearing children have been deprived of language and the impact that has on them. And again, as an adult, that could be misdiagnosed as a learning disability, potentially. We don't diagnose children with personality disorders, and we don't tend to diagnose children with psychotic disorders such as schizophrenia. And the reason for that is generally because those don't start to emerge until 18 to 25 area. And our criteria goes up to 18. So next slide. So this is the referral to discharge summary for National Deaf CAMHS. So we received a referral, and what we tend to do is offer a first appointment. The first appointment will, before we go out, it will be arranged by 3 people, as I've said before. You'll be a hearing clinician, your deaf outreach worker, and your BSL interpreter. And those components come together very nicely and very necessary. And so as the 3 of us, before we go to appointment, we'll always have a pre-brief. We'll look at the referral, the reason for referral, what the aims are of the session, that the first appointment, what we want to get out of that, what information we want to gather and how we're going to gather it, who's going to gather it. And everybody's perspective is very different. So I will go in with a very hearing mental health perspective, where the outreach worker, the deaf outreach worker, will go in from a very deaf lived experience from their perspective. And the BSL interpreter will also go in with a completely different perspective and also bridge. And then after the first appointment, we'll actually have a debrief as well, where we'll feedback those different perspectives, which will bring together a whole, which will bring a really, really good, richest first appointment and assessment. In addition to that, the specialist deaf outreach workers will carry out what we call communication profiles. So they will look at communication in the home and how they access information from their parents to be parented, general conversations within the household. The other part of that is that they will also go to school, because that's the other half of the child's life, where they spend time in school. And they will look at how they access the curriculum and how they are able to have peer conversations and peer regulation, in development and conversation that you learn from your mates at school. So again, it's access to information. And to do that, they'll carry out a school visit. So when they go and do the school visit, that's what they're looking at, access to information and the curriculum. When I go and do a school visit, I'm very much looking at it from more of a medical, sort of emotional behavioural aspect. So I'm looking for the signs and symptoms of maybe ADHD, where they will be looking at communication, but however, they can merge because ADHD will come out in communication. So they will sign or talk quick. They will flip from one conversation to another. And so they sort of do merge, but and it's very interesting when you see that. Once we've done the assessment, we've done the home visit, we've done the school visit, we'll gather reports from any other professionals, we'll liaise with who we need to. We then pull that all together in one report and we look at what we think's going on for this child, what are the problems, what are the difficulties, and that's called a formulation. And at that point, when we've pulled it all together, we all agreed with it, then we will then discuss the feedback with parents. Sometimes parents are happy to hear the diagnosis and other parents aren't ready to hear it just yet. And so we have to gauge how we do that as well. And it's much more, we rely much more on our BSL interpreters and our deaf staff when we're feeding back to deaf parents. In addition to liaising with other professionals to gather our information, when it also comes to intervention, we will happily co-work with local CAMHS. So an example would be is where I've worked with the deaf parents and we've done some parenting because they couldn't access any other services that did parenting because it was all for hearing parents. And the child who's hearing would actually go to local CAMHS and have assessment and treatment for ADHD, for example. And the two of us together as a hearing and deaf CAMHS work together for this family, and that's worked really well. There's a variety of interventions after we've done the assessment that we can offer, and that we also, which I will go through shortly. But there's also a lot of signposting that we do because we're not always the best service to offer the intervention. Sometimes it can be school or other more specialist services such as eating disorder services. And that's where we will then help them, excuse me, have a better understanding on how to work with deaf people, help them book, how to book interpreters, to help and scaffold them so they can offer the family the intervention they need that we can actually offer. We do 6 monthly reviews. If the children stay with us, we do the intervention and we review every 6 months if they continue with us. As we said before, it's quick in and out where possible, very focused, very intense, rather than dragging interventions on. And so we do the 6 monthly reviews with the aim to discharge as soon as possible. So, next slide. So the usual reasons for referrals are query anxiety. So that's where a child may be struggling in school, maybe having panic attacks, their heart's racing, they're having thoughts in the back of their head that's running fast. And it's more than just worries, you know, it's the impact, the effect of anxiety is a lot worse than just a fleeting worry of a thought of a worry. Behavioural difficulties is the biggest proportion of our referrals, and more than often it's our job to unpick what's causing that behavioural difficulty, and that's how we do that by going through our assessment process. Some referrers would say that the child has a query cognitive difficulty and they want us to assess whether that's true. So again, we'll assess that. We get referrals for gender and sexuality issues. And this is usually because the child is struggling about having these thoughts and feelings when his peer groups aren't accepting. If the peer group's accepting, it's different. But if the peer group or the family members aren't accepting, then that's usually when we get a referral for that. Language deprivation, again, is, like I said, it's a new area. that's coming into the UK. It's always been around, but the research is growing. And because there's no, the language disorders, there is a diagnosis for language disorders for hearing children, but there isn't anything for deaf children. There's never been any research done on it, and so there's no diagnosis. And so language deprivation we're seeing more often. Identity and CODA, so that's child of deaf adults. So we'll get children who have are struggling with their identity of being deaf, but we also have, because they're different, but we also have children who are referred to as hearing children because they've got deaf parents, and again they're different, and so their peers, as cruel as they are picking on them for that very reason. In addition, they might have additional responsibilities within a family where there's deaf parents because services aren't equally accessible, and so there's additional pressures there for a CODA, a child of deaf adults. Low mood and self-esteem is another quite common referral, and that's again due to life pressures and lack of resilience a lot of the time, and parenting, but also peers. Peers are cruel, and now they can bully you 24/7 because of the internet. But the reasons for low mood and self-harm do vary. We have queries about whether children have ADHD or ADD. We have queries around autism. Self-esteem and confidence is another one, again, that links with the low mood and self-esteem. So it starts off maybe as a bit of identity, it affects the self-esteem and confidence, then it moves into low mood and self-harm. And you can see the progression building, and it depends at what stage they come to us. Again, if it's on left, if you remember the slides before, if those are on left, that development continues and you end up with someone who can be quite severely depressed, isolated and self-harming. We'll have referrals for sleep issues, not an uncommon one, especially with the younger children, and that's to look at whether it's a parenting aspect. With all these, we look at whether it's a parenting aspect and what can we help the parents to do, and do we need to work with the parents, or is it a child thing? If it's just routine, then we support the parents when it comes to sleep. If it's something a bit more serious and the child is really struggling and having sleep difficulties, then there may be some additional things that besides education that needs to happen. So for example, we'll always educate first, see if it makes a difference, and if not, then they'll go to one of our medics to look at some medication to help with sleep. Trauma, abuse, neglect, we do see quite a few of them, but fortunately we don't have a huge amount, which is quite positive really. And then we have eating problems. Again, the eating problems is usually because of something else. Children just don't tend to have an eating problem per se like they would have maybe autism, because it was there from birth. Eating problem usually comes again as usually because something's happened to them. It's a trauma or bullying. It started with low mood, and then the self-harm in this instance isn't using any object to harm themselves, but actually it's about withholding food, because that's one of the things they feel they have control with. Next slide, please. So I mentioned before about the assessments that we do. Every child will get a full assessment. So they're referred for different reasons. We will look at what's causing the reason for referral. And at the same time, we do a holistic assessment. So we'll look at everything really. So other things might come out as well as. So we always look, every child will get an in-depth full assessment, a standard full assessment. So that includes family history, of their parents, grandparents, to see if there's anything running in the family, birth history of the child, right from pregnancy, through pregnancy, to birth, and whether the birth was a normal birth, whether there were any complications at birth. Then we look at developmental history from the child around, when did they crawl, start standing with the furniture, walking, saying the first word, stringing the sentences together, what age were they. There is a natural developmental process that most children go through. And we gauge roughly where children should be. And when there's a delay, then you look at why that might be. We look at deaf history. So when they had their newborn screening, when they were identified as being deaf, what hearing aids did they get provided? What support did parents get? Did they wear the hearing aids? Did they get referred to the implant team? All that impacts on our assessment and formulation. We then cover education, what type of school they went to. Was it a mainstream school? Is it, did they go to nursery? What sort of support did they have? How have they been able to access that? And so the communication assessment informs all of this as well. Sleep, we look at an appetite, predominantly because when there is presenting emotional behavioural concerns that are more on the mental health side, you usually find it affects your sleep and appetite. So for example, depression, anxiety, those are the two sort of like main ones. Your sleep and appetite will always tend to be affected if they're disabling and at that level. And then we look at the presenting concern. What is it that you want, that the parents want help with? What is it they want? Do they just want a diagnosis? Do they want help? Do they want support? Within there, because we're a mental health service, we need to do a mental health risk assessment. Like I said, you do sleep, appetite, presentation, interest. And is there any harm to themselves, harm to others, and are they vulnerable, being neglected, being abused? Anything comes into the risk assessment, including additional physical disabilities that they might have. So the knowledge of these specialist tools, of the main assessment is needed by all three components I've mentioned before: mental health practitioner, deaf outreach worker, and the BSL interpreter. We will also do, we're also able to do more specific focused assessments following the full assessment. So if the referrals say for autism or ADHD, then there's additional tools that help us unpick the sort of components that would help a diagnosis of autism or ADHD. So for example, for a cognitive assessment, there are specific tools like the WMV and the WISC. So the WMV is like a non-verbal assessment, so it's sort of can be adapted better to our children, our deaf children, where most of the other assessments for cognitive assessments to see is based on hearing children. For autism, we'll use tools called the ADOS, and now we have an ADOS 2D tool, which was translated because the ADOS is based on hearing children, where so for example, there's a component in there to look at joint interest, because children with autism don't tend to have joint interest. And so for example, the phone would ring and you go, oh, the phone's ringing, and the child a hearing child with normal interest should look where you're looking at and be interested in the phone ringing. Now with deaf children, if not aided properly, for example, or who aren't aided at all, who aren't able to go and hear the phone ring. And so this is just one small component of many components within the ADOS assessment tool for hearing children that didn't fit for deaf children. And so through our research team at the York University, we were able to work with them and actually create an ADOS 2D. And so things like the phone ringing for joint interest has now been changed and is much more sort of like focus for deaf children and accessible by deaf children. We've got the another assessment tool for autism is the ADIR. Basically, that is it's a bit of a checklist for questions for you to ask parents around the early developmental things, about did they reach the early developmental milestones, or were they delayed, and if so, which ones were they and how long were they delayed, and current presentation as well. To help us with the diagnosing and collecting information to help us see if there's a diagnosis of ADHD, we'll send out things like Conners questionnaires. We'll send them at home and at school, because ADHD has to be prevalent in more than one area. It has to be in all areas of the child's life. And we'll look at the information that we get back. So we'll be looking at things like fidgeting, attention, concentration, organisational skills, time management, patience even, and the general presentation. Do they look like, are they rushed? Are they bothered about tying the shoelace and things like that? You do have to be mindful of the things like of the things I've just mentioned, of fidgeting, attention, concentration, and organisation. You have to be very mindful that you don't use the Conners questionnaire on its own, because those sort of symptoms are also potentially symptoms to help us diagnose attachment issues. So it's our job to unpick the differences. The brief, this is a, sorry, I've lost my slide. Bear with me. There we go. So the brief, this stands for Behaviour Rating Inventory of Executive Function. It's easier to say a brief, I know. So a brief is an assessment of executive functioning behaviours. So it's your frontal lobe, okay, and that's the part of the brain that does things like so it's all manages. It's your control. It's your little person inside. So, you'll have these thoughts where you'll say, "Oh, I want to tell them what for," but the little person inside says, "No, you shouldn't do that. You need to do it in a very different way." That's the bit, that little person, that people with the executive functioning difficulties don't have. And so then it could be seen that they're naughty, they're aggressive, they're cheeky, they're arrogant, the behaviour's all over the place, where actually it's the brain functioning. We do BSL, specialist BSL productive receptive tests. This is something that our outreach workers will do. And they'll tend to co-work it most of the time with our BSL interpreters as well. And they'll also link in with some language specialists. So the BSL productive receptive test is sort of like on a par where a hearing child would have their English assessed for their age. And they can do that in schools by using, child reads a story, and the teacher then looks at what level the vocabulary is, how they're pronouncing the words, forming the sentences, and actually able to flow with the story. There isn't anything for hearing children in mainstream education, and this is the BSL productive receptive test. It works alongside that sort of like. It looks at flow, it looks at vocabulary, it looks at hand shapes, it looks at understanding and memory. And they do this by going through a story. And so it's quite, again, instead of reading a book, it's watching a video. It's a story about a spider, and they tell the story. And from there's a bit of a score sheet, and it gives you feedback on areas of development and areas where they're actually doing well at. Sometimes we can actually do a specialist language assessment. So one of our deaf service consultant and maybe an external language specialist in the deaf community could co-work and do a more in-depth language assessment, more so than the communication profile, which just gives us it gives us the access to information at home and access within school for child development. The language assessment can give us a lot more about hand shapes and flow and whether they're pronouncing words clearly. It's a bit more like a speech and language therapy, but with deaf children, language assessment, but with deaf children. We do have an occupational therapist, and they can offer occupational therapy. It's not physical occupational therapy. It's more around working with, like, say, children with ADHD or attachment, to help them organise themselves better, to get up in the morning, to get dressed and to school on time in the right uniform, which some children do struggle with. Sensory services, we usually refer out to. At the minute, I've got one staff member in each of the teams. They're all going off and being trained today as we speak on sensory profiling, which, because we do get a lot of children with sensory issues, so they like feel of things or the weight of things or different temperatures, and we need to be able to advise parents on how they can manage that better. And sleep, as mentioned before, there's a specialist. If we think a child's got sleep issues, there are certain specific tools that have been invented for hearing children, but we're all people and we all need to sleep. So it's about, is the routine there? What time do you go to sleep? How many hours are you sleeping? What's waking you up? In addition, the deaf things that come into that adapt it, if you like, would be is that in a hearing sleep assessment tool, you wouldn't be saying, when do you take your hearing aids out? Do you hear anything when you do that? Do you have tinnitus? Those are different aspects of a sleep assessment for deaf kids that you wouldn't get in a sleep assessment for hearing children. Okay. The other thing to bear in mind, just going back to autism, is that we wouldn't start to do assessments for autism until the child's around 2 or 3. I think that the criteria, the medical criteria, is from 3 and up for a hearing child. Now, deaf children, we tend to wait and give the child another 6 to 12 months to catch up, rather than, because it could just be a developmental delay rather than actual autism. So we have to unpick that. And that's something else that we do differently than hearing services. Okay, so next slide, please. So we've looked at reasons for referral, we looked at what the service can offer, the reasons for referral, who's on the team, how we do our assessment, our specialist assessments, who's involved. These are now some of the interventions that we can offer. So if we're going to be offering the intervention, for example, if it's identity, particularly deaf identity, or general identity, or sleep, emotional literacy, we'll offer emotional regulation and anger management, parenting a deaf child, because obviously not many hearing parents are geared up for that, and low-level anxiety and mood. All those types of interventions our specialist deaf outreach worker will carry out. Mental health workers will tend to do things like CBT, DBT, and EMDR. They're specific therapies. So CBT is cognitive behavioural therapies. The concept is it's based on your thoughts, your feelings, and your behaviours, and they're all interconnected. And the idea is that they want to change your thought, which then changes how you feel and how you manage things that are quite overwhelming problems, and change your thought into much a more positive way. So rather than thinking, if I touch that, I'm going to end up with, like, a really bad disease all over my hands. If I walk out, I'm going to get knocked down by a bus. They start to unpick on, get you to unpick, and actually, how realistic is that? What sort of things, and change that thought that actually a roof tile's going to fall on your head every time you open a front door. Because what's the likelihood of that happening? And it's convincing your brain and that thought and changing it into a positive thought, reducing that thought so your behaviours and your feelings don't then become affected. DBT is dialectical behavioural therapy. This is a type of cognitive therapy, but what it does is it gets where the cognitive behaviour therapy does your thoughts and feelings and behaviours. This DBT usually works with a negative thinking pattern and pushes for a positive behavioural change. I know it sounds very similar. So my way of thinking for DBT is that it's used with much more suicidal and self-destructive behaviours. So it's no longer at a cognitive stage that can be changed, and you've now moved to the behaviour therapy, and it's focusing more on the behavioural side of things to prevent you from harming yourself rather than just having negative thoughts. EMDR is short for eye movement desensitization and reprocessing. So EMDR therapy is used more for trauma, historic trauma, and it uses your eye movements and eye flickering to try and train the brain to process things. In layman's terms, in my understanding of it, is that a trauma happens and you bury it really deep at the back of your mind, and you carry on your life, but little bits seep out until a point where it's struggling, it's affecting your lifestyle and how your daily living. And so the idea is with EMDR is that you've filed it away. You haven't actually coped with it. You haven't done right. I've sorted this out. I've managed with this. I've dealt with it. Let's file it. It's still there and it's all over the place and it's no order to it. And so the idea is EMDR is to bring it back to the forefront, which means you relive your trauma. So you have to be careful, particularly with children, when you do that, because they might not have the emotional literacy or the emotional maturity to cope with it again. So they bring the trauma back out in bits and it's everywhere, swirling around, and they make you go through the trauma again. File it all nicely neat in order, make you go through it in a safe environment and put it right back, but in one place now because it's been dealt with. And they reckon that by using your eye movements with the brain whilst you're talking about and recalling your distressing events, it's supposed to emotionally reduce the upset that comes along with it, and you're able to manage and deal with it and put it to rest. Okay, next slide, please. Okay, so as a BSL interpreter, BSL/English interpreter, obviously we work with other interpreters as well, other spoken language interpreters, but we do bring those in on an ad hoc basis. They're not part of our team. So as an interpreter within our service, where could you actually interpret? Anywhere, basically, whether it's in the clinic, office, in National Deaf CAMHS, whether it's in a mainstream CAMHS room, we can do it in school, GP surgery, social care building, a children's centre, any sort of like NHS or hospital site. Our first appointments as a rule when we're out there in the community tends to take place in a person's home, the family home. We'll use outpatient departments and clinics, inpatient units, and this is the same for all sorts of follow-up appointments. We'll just do them wherever the child is. Ideally, we do the first appointment at home, so we get an idea of the child. We first meet the child in a nice home environment. We see how the family function to a degree, let's get a snapshot. And school would be the other place that we tend to visit. When we're doing interventions, we tend to do the interventions in a school environment because the child's in a learning sort of ethos, and that's usually what we're trying to do during our intervention, is to teach them something to help them manage themselves better. And then the other place would be maybe a children's centre or an outpatient service or a GP. Next slide, please. So although we've talked about the reasons for referral and the types of referrals we get, these are usually the things that we find cause the reasons for the referral in the first place. So before, when I said like we'll get a referral for behaviour, where actually when we unpick it all and we do our assessment, we actually see that the communication within the home is not great. So the child is preferring to use BSL maybe, for example. The parents are oral, they don't sign, they use spoken English. And so how do you expect a parent to child how do you expect the parents to parent a child? And likewise, how would you explain to a child about reasoning or about a sleep routine? And so the outcome and the reason for referral is behaviour, but actually we find out that it's language communication difficulties. Another one is childhood abuse. So again, we'll get referrals for maybe self-harm, low mood, but when we unpick and we look at what's gone on through our assessment process, we actually find it's childhood abuse or neglect. Family relationship difficulties. So you've got parents who maybe have mental health issues of their own. Again, the language and communication differences. You've got just parents that are unavailable, maybe post-traumatic stress. They weren't available for the child in the early years. And so the child then realizes that, you know, when they cry, mum comes as a normal thing, but actually for some children, mum doesn't come. And so they learn to manage on their own, and that's not healthy attachment. And so we start to see family relationship difficulties that are causing attachment problems. Identity or difference, I've put, because that's not just deaf identity, gay identity, but even because, you know, there's the identity can have many different sort of aspects within there. But for a lot of our children, it's usually they're because of their hearing loss. Additional sensory and physical learning disabilities and difficulties because of the, you know, some of our children can have like syndromes where deafness is one component. School is a biggie. Like I said before, kids are really cruel. Bullying, kids not doing as well as what they see their peers doing. They see that their curriculum is differentiated. And then you've got your difference between your mainstream school and residential school, and your pros and cons for that for our deaf children have asked. So you've got deaf children in residential schools picking up BSL, living residential and then going home at weekends and not being able to communicate with their families. And then you've got children in mainstream school that are quite isolated. They can't hear their peers in their playground. And although they've got friends at home locally, compared to kids who live in residential and go to, you know, schools that are much further away, they don't necessarily have the communication skills to have relationships with their hearing peers. So, next slide, please. So additional difficulties, I mentioned the syndromes where deafness is one of the components. So, for example, Charge syndrome, Waardenburg's and Usher's. Could spend a whole day on these, so feel free to have a look on the internet for more information. Other causes of deafness, we look at the cause of deafness, which is quite important to inform our assessment and formulation. So, for example, prematurity, rubella and meningitis, they're three quite common ones. Meningitis, for example, will affect the frontal lobe, which is your executive functioning again. So that manages your emotions, your inhibitions, that little inner regulator that tells you what right and wrong, and don't actually blurt it out. You shouldn't be saying that, it's rude. Those sort of control things don't actually take place. And so we get a referral for a naughty, cheeky child with behavioural difficulties. But actually we unpick it and we see that it's something else. Other additional difficulties are not easy to pick up, to unpick sometimes. So a child can actually have learning disabilities or and language communication impairments, as well as so sometimes it's really difficult to unpick whether it's a learning disability. Did it derive from language deprivation? And, you know, is it looking like a learning difficulty because of language deprivation, which is due to the hearing loss? And sometimes we can track it back, but sometimes we can't. And so we just, you know, we look at what the concerns now and what is it that parents would want help with. Next slide, please. Okay, so this is my last slide, and it's examples of difference. So I thought I would look at giving you a bit of a case study. So, which explains like the difference of hearing services versus deaf services, and how those lack of skills and knowledge and staff members who have the deaf experience in a deaf service, how that can make such a difference to a child compared to a hearing service. So before our service began, it was set up, a child aged 4 was taken to the paediatrician by his mother. Now, Mum reported, it was Mum's report, that her kid was a naughty child. He wouldn't do as he was told. He wouldn't go to sleep. He had odd behaviours like lining things up. He didn't like change. His speech was delayed. He was delayed. And Mother wasn't coping and was feeling depressed. The child is deaf, okay, was born deaf. And those days they were diagnosed late as a rule, and the equipment arrived late, and there wasn't the same support around hearing and language and communication. So the paediatrician sees, oh, Mum's struggling with a deaf child. Yeah, so I'll give you some help. I'll prescribe you some medication so the child can sleep at night, so you get more sleep, so the mum gets more sleep. And so I'll give him something to calm him down as well. Oh, and because of the things that you're saying about his behaviours and lining things up and change, it sounds like he's got autism. So the paediatrician gave him a diagnosis of autism as well. And this, he also suggested Mum goes to the GP, because the paediatrician sees the children and the GP will see the adults. And so Mum would go to the GP, and the GPs prescribed Mum antidepressants. So that was when the child was 4 years old. At 13, we get a referral from the teacher of the deaf, and he comes back to us. And the referral again is come because Mum's not coping. He's going through adolescent. Most parents don't cope. But this mum was saying that the old behaviours are still around, they're getting worse, even though he's on medication. And it's because he's got autism and I want help. Okay. So he was referred for the behavioural issues predominantly. So I did the full assessment. I did the historic, the family, the birth, the history, the deaf history. And actually, as I went through all the developmental history and the birth history, I was seeing that this young man, this young teenager, was not meeting the threshold for autism. He lined up things, but that was because he didn't know what was coming next. He didn't like change because nobody told him what was coming. So his way of managing the world and making some security about it, because, you know, every so often Mum would just pick him up and take him somewhere. He wouldn't know where he was going because nobody spoke to him or he didn't understand. And we looked at the developmental process, and actually it was a little delayed, but he wasn't too bad for crawling and walking. He was delayed with his speech and his language, but that was the only area. His eye contact was fine, and he was interested. He shared joint interests. So if I looked and startled and looked away, he did the same. And again, this is not something that a child with autism would tend to do. He was generally interested in me, would ask questions about me, even though it was something he wasn't necessarily interested in, where a child with autism, it would be all be, you know, if they're interested in dinosaurs, then they'll ask you about dinosaurs. But he was actually asking me, you know, spontaneous questions that he was actually interested in. And they were appropriate questions. Eye contact was good. He could reflect in the moment. He had a little bit of quirkiness, but he was quite a dramatic, sort of like feminine young man. And he preferred BSL. His mum, however, didn't sign. She said that sometimes he chooses to ignore her. And Mum was still struggling. So what I ended up doing was going back to the paediatrician and actually having this child's diagnosis of autism removed. And we also removed the medication as well. And I spoke to the child, and what it was really is that what happened back in those days is that the paediatrician had taken Mum's struggle and her inability and difficulties around parenting and didn't realise that that was the main issue. It was Mum that needed the help around having good bedtime routines, and it was Mum that needed help to be able to communicate with her child, to enable her to parent her child. And instead, this child was wrongly diagnosed with sleep issues, behavioural issues, and autism. And it was a time where I actually spoke to the child, and he, at 13, he couldn't believe that he'd been wrongly misdiagnosed all these years. And in the end, we ended up supporting him through that period of time where he'd actually had this, he thought he had a label of autism, and he hadn't anymore. He thought he was, labelled the naughty child and needed medication to calm down, where actually he just needed support around his sleep pattern, and he needed his mother to be able to communicate and parent him. So that was a very interesting case, and he's now a very young, happy man, and no longer on medication, and he doesn't have an autism diagnosis. And this is what happens sometimes with hearing services who are inexperienced, untrained, and don't have the deaf experience like we have on our team. So thank you very much for listening. I hope you've had a lot of your questions answered. I'm sure I may have also raised a lot more questions. So if we move to the next slide, I'll be happy to try and answer any questions you may have. Thank you.